So my name is Mark Dawidek. I'm one of the third-year urology residents here at the University of British Columbia, and I'm going to be presenting today on the topic of a definitive radiation-based treatment for muscle-invasive bladder cancer. I'll be predominantly focusing on this from the perspective of so-called trimodal therapy. So as a brief introduction, radical cystectomy is, of course, the widely accepted gold standard treatment for muscle-invasive bladder cancer. However, there's been a shift towards organ-sparing paradigms across disciplines. This is particularly in organs having significant impact on quality of life, which includes the bladder. It also offers the opportunity to extend treatment to patients who otherwise would not tolerate the morbidity of radical extraoperative surgery. Also, a quick clarification on terminology. Bladder sparing is an umbrella term. So all treatments listed here, transurethral, resection, partial cystectomy, radiation therapy, and chemotherapy, on their own or in combination are considered bladder sparing. And an important caveat is that they're individually oncologically inferior. Trimodal therapy then, which you may also encounter referred to as multimodal therapy, and I'll have it abbreviated as TMT throughout the presentation, specifically combines maximal transurethral resection, definitive external beam radiation therapy, and concurrent radiosensitizing chemotherapy, an attempt to maintain the bladder-sparing paradigm while optimizing oncologic outcomes. Some objectives and overall structure for the discussion this morning. So I'll start by examining subgroups of patients with muscle-invasive bladder cancer and highlight who might benefit from trimodal therapy. Then review the details of what trimodal therapy actually entails before scrutinizing the evidence behind it. Lastly, we'll explore some novel developments in this space. So starting by looking at the role of trimodal therapy in different subgroups, the first patients are those identified as so-called optimal patients or optimal candidates for trimodal therapy. These are patients selected from candidates for radical cystectomy. At the very least, they have resectable clinical T2 to 4A and 0M0 disease, and medically fit for the operation. In these patients, trimodal therapy is a choice, typically with a goal of maximizing quality of life. However, since they are candidates for radical cystectomy, there's a strong emphasis on ensuring optimal oncologic outcomes. Indeed, these should be essentially equivalent to radical cystectomy. Therefore, it is important to identify what factors might be predictive of trimodal therapy outcomes. Of course, the patients should be eligible for radiation therapy, and contraindications would include previous pelvic radiation, severe inflammatory bowel disease, certain connective tissue disorders, and certain radiation sensitizing syndromes. Most guidelines, including the CUA, suggest the following as tumor and patient factors predictive of good response to trimodal therapy. Majority resectable tumor on TUR, and the radiation oncologist like to see a maximal TUR performed. Low stage disease, and these two first points are really not independent. Low volume disease, no diffuse CIS. Traditionally, we hear no CIS, but focal CIS adjacent to the tumor is typically acceptable. No hydronephrosis. Chemotherapy eligible, and this is specifically radiosensitizing chemotherapy we're talking about. We'll discuss some of the regimens a little bit later. Adequate bladder capacity and function, and motivated patients who are, of course, going to be compliant with cystoscopic follow-up. Caveat is that there's no strong level of evidence identifying these optimal patients. These predictive factors are pooled from multiple trials and studies. And as we'll see, there has actually been no direct comparison with radical cystectomy. An additional important consideration is the radiosensitivity of histologic variants. There's very limited data with respect to the urothelial variants. There is a recent retrospective study of about 300 patients from the group at MGH, which suggests no difference in outcome. at least when it comes to squamous and glandular differentiation. However, really, they have insufficient numbers to draw any sort of conclusions regarding the more rare variants. With respect to the distinct variants, there is evidence that squamous cell carcinoma is radiosensitive, but radical cystectomy, primary radical cystectomy, is still typically the favored treatment. Adenocarcinoma is more radioresistant, and again, primary radical cystectomy is the favored treatment, or partial cystectomy in case of urachal disease. Neuroendocrine or small cell carcinoma actually has a long-standing history of predominantly radiation-based treatment, as it is quite radiosensitive as well as chemotherapy sensitive. And sarcoma is predominantly a surgical disease and is typically radioresistant, though this does vary with the specific pathology. So an estimated 10 to 15% of patients fall within this narrow definition of optimal candidates for trimodal therapy. What about the patients who are eligible for radical cystectomy but are not, quote unquote, optimal? Some might refuse radical cystectomy and end up with trimodal therapy. What are the outcomes in these patients? This raises an important point. Many of the predictive factors for trimodal therapy overlap with radical cystectomy. Examples include stage, hydronephrosis, and so these patients would be expected to do worse with radical cystectomy as well. Once again, this optimal definition is not based on any strong level of evidence or direct comparison with radical cystectomy. So really, in these patients, it's uncertain if surgery has a better or equivalent outcome. At the other end of the spectrum are the patients with unresectable disease at presentation. Generally, this portends a poor prognosis, but some may be eligible for radical therapy, specifically the patients with clinical T4B or N1 to 2 disease. Radiation therapy with and without radiosensitizing chemotherapy is sometimes administered with curative intent in this context. In particular, if the patient receives primary chemotherapy and demonstrates significant response, they could be considered for consolidative therapy. And of course, we'll not be focusing on radiation without curative intent this morning. Last are the patients with technically curable disease who are medically unfit for radical cystectomy. The emphasis in these patients is on the lower morbidity offered with trimodal therapy while still offering high-quality oncologic outcomes. As with radical cystectomy, some patients meet optimal definition while others don't. However, in this population where there are limited other options, criteria is generally relaxed, and this is a less important distinction. Furthermore, since these patients are less medically fit, some may be receiving radiotherapy without radiosensitizing chemotherapy. We'll take a look now at why this is actually a very important population with respect to trimodal therapy. A number of studies have investigated treatment patterns in muscle-invasive bladder cancer. These two shown here are amongst the most cited, and they encompass 2 consecutive decades of SEER data in similar patient populations. And these are older patients with T2N0, N0, so quite curable disease. Shockingly, only about 20% of these patients underwent radical cystectomy, and this was actually consistent across the decades. And age and comorbidity were associated with a decreased likelihood of receiving radical cystectomy. So these studies point out to underutilization of radical cystectomy, especially amongst older comorbid patients. They did look at chemotherapy and radiation therapy, but not really in a granular way. They lumped it all together. So natural hypothesis might be that trimodal therapy, which incurs less morbidity, is compensating for the underutilization of radical cystectomy in these patients. A study using the National Cancer Database, looking at a slightly broader patient population than the SEER studies, which included younger patients and more advanced disease, once again found underutilization of radical cystectomy, as well as underutilization of definitive radiation therapies, as it's highlighted in the diagram here on the right. Both were once again associated with increased age and comorbidity. And shockingly, in this population, 25% of patients were managed with just observation. So is trimodal therapy or radiation-based therapy compensating for the underutilization of radical cystectomy? No. And this is not an anomaly to the United States. I don't have the data here, but similar proportions were found in a recent Swedish population-based study. And there were unpublished reports of data from Ontario, which also have similar proportions. But is this truly under treatment? This is a single center retrospective cohort from the group in Sheffield in the UK. It looks at about 900 patients, and they similarly found that older patients were less likely to undergo radical treatment, but they also performed a competing risks analysis. And what they found was that cancer-specific mortality was associated with age, while other cause mortality was stable with age. This is counterintuitive. You would expect in these comorbid patients for other cause mortality to increase with age. And this suggests that older patients are dying of their cancer and not their comorbidities, which points to undertreatment. This highlights that the decision to treat cancer should be based solely, or should not be based solely on age, and that competing risks and comorbidities are less relevant in bladder cancer since it is a more rapidly progressing disease. So the underlying point of this tangent is that there's room for improvement. We can optimize the number of candidates for radical cystectomy with improved patient selection. And this is a whole separate topic. And there's potential to address undertreatment in those medically unfit for radical cystectomy with expanded use of trimodal therapy. So we'll now look at the details of what trimodal therapy actually entails. And this is going to be presented from the perspective of patients who are eligible for radical cystectomy and have a choice between surgery and radiation. There are two accepted regimens. They differ in the timing of cystoscopy and biopsy. The split course regimen begins with maximal transurethral resection, followed by induction chemo and radiation, and then cystoscopy and biopsy. And if there's evidence of complete response, it's followed by consolidation chemo rads. On the full dose, the continuous course administers the full dose of chemo and radiation before taking a look. In British Columbia, we typically opt for the continuous course regimen. There is some suggestion that the split course has an increased margin of safety. There's no prospective data comparing these regimens. Most guidelines recommend including a biopsy in the initial cystoscopic assessment. It can be difficult to distinguish radiation-induced changes versus viable tumor, and it's possible to have viable tumor deep to normal bladder scar. And this is more specific to the split course, but there is evidence that consolidation treatment is safe even after TA or TIS disease after initial induction. So complete response is considered as no visible tumor, negative biopsy, and negative cytology. I think it's important to frame this as an attempt at bladder preservation and not necessarily an expectation. And surveillance and radical cystectomy are integral components of the regimen, not necessarily a failure. Urologists are involved in a number of these steps, but truly trimodal therapy is founded on multidisciplinary care. The group at Princess Margaret have published on their model of a multidisciplinary bladder cancer clinic, in which the patient is actually seen simultaneously by urology and radiation oncology, with medical oncology immediately available. The first step is, of course, transurethral resection. The recommendation is to remove all visible tumor and consider re-resection in order to do so. There's evidence, and the image here is from the MGH group, but it's been reproduced by other groups, of improved disease-specific survival and overall survival associated with a complete TURBT. However, there's a huge caveat here that there's very much that this is very much confounded by stage. The role for enhanced visualization in the context of trimodal therapy has not been evaluated or studied specifically. However, it might be useful in evaluating the degree of CIS. And documenting the tumor location helps facilitate radiation planning, and at the very least, this should be descriptive, but ideally involves placement of fiducial markers such as gold or iodized oil, which is done in a similar manner to Botox injection. Radiation is delivered as external beam radiation therapy in either a 3D conformal or intensity modulated technique. The bladder can be a challenging structure to target. Novel techniques include image-guided radiation therapy, which involves intra-treatment imaging to improve alignment, and adaptive radiotherapy, which involves adapting the treatment plan to dynamically the changing anatomy of the bladder. The typical doses to different volumes are highlighted here. There's some controversy regarding the field. There's rationale for treating a larger pelvic volume and including more lymph nodes, which is analogous to an extended pelvic lymph node dissection and radical cystectomy. However, surprisingly, there's no strong evidence of benefit, and it might increase toxicity or impact future urinary diversion. Fractionation can be once daily or twice daily, and there's some radiobiological rationale for twice daily or accelerated fractionation. This is practically challenging, and again, without strong evidence of benefit and potential of increased toxicity, we tend to, in BC, to opt for once daily fractionation. The importance of concurrent radiosensitizing chemotherapy is well established. Cisplatin is long known as a radiosensitizer, and actually the first randomized phase 3 trial looking at cisplatin with radiation in muscle invasive bladder cancer was performed here at UBC with Dr. Sullivan as the PI. And this demonstrated improved local control, but did not detect a benefit in overall survival, although it was probably underpowered for this outcome with just 99 patients. The challenge is that many patients are ineligible for cisplatin, especially if we're looking at the patients who are medically unfit for radical cystectomy. So this landmark randomized phase 3 trial from the UK, James trial, BC 2001, looked at using mitomycin C and 5-fluorouracil in place of cisplatin. This improved local control, which was their primary endpoint, and there was a trend towards improved overall survival, which was thought to be dampened by salvage cystectomy. And this raises an important point that chemotherapy is not expected to have systemic effect at radiosensitizing dose and schedule, i.e. it's not targeting micrometastases. The improved overall survival is through improving local control. And that's why the thought is that salvage cystectomy might mask this effect. It also suggests that neoadjuvant or adjuvant chemotherapy might be synergistic with trimodal therapy. Another important result from the BC 2001 trial was that there was no significant increase in toxicity with chemotherapy. And a recent RTOG trial suggests that gemcitabine also has acceptable efficacy and toxicity. So there are gentler regimens which are available, which are effective, and these can help expand the treated population. But there are no phase 3 trials comparing these regimens versus cisplatin. So I already alluded to this, but neoadjuvant chemotherapy is thought to improve survival by treating occult micrometastatic disease. The BA-06 trial is another landmark randomized phase 3 trial, the largest investigating neoadjuvant chemotherapy in muscle-invasive bladder cancer. And it actually had a large proportion of patients who received definitive radiation treatment. The long-term results, published in 2011, reported a statistically significant 6% absolute overall survival benefit. And interestingly, on interaction analysis, the benefit was independent of treatment modality. There have been a number of systematic reviews and meta-analyses looking at neoadjuvant chemotherapy in muscle-invasive bladder cancer. The most recent, in 2016, reaffirmed an 8% absolute overall survival benefit. And it was actually based off trials including including radical cystectomy, radiation treatments, or both. As a result, neoadjuvant chemotherapy is widely accepted as standard of care for patients undergoing radical cystectomy for muscle-invasive bladder cancer, though there is concern that it remains significantly underused. In trimodal therapy, neoadjuvant chemotherapy remains less established. This stems from the fact that while the studies just mentioned are supportive, the high-level trials looking specifically at neoadjuvant chemotherapy with trimodal therapy have actually been negative. The most cited trial is the RTOG 8903 trial. This is an older randomized phase 3 trial looking at neoadjuvant cisplatin, methotrexate, and vinblastine. And it actually demonstrated increased toxicity to the point where it impacted completion rates with no difference in outcomes. This trial and others investigating the same question, however, had significant flaws. Namely, the chemotherapy was often inadequate. In the RTOG trial, they were only 2 cycles. There were lower treatment completion rates, and we might see higher treatments with some of the more or higher completion rates with some of the more gentle chemotherapy regimens. They were limited to small sample sizes and were underpowered to detect the significant effect. And many of the patients enrolled in trimodal therapy trials are highly selected and have very favorable pathology, which might dampen the effect of chemotherapy, neoadjuvant chemotherapy. However, as a result, some centers, notably the Princess Margaret Group and their multidisciplinary bladder cancer clinic, and on reasonable grounds, do consider neoadjuvant chemotherapy as the standard of care with trimodal therapy as well. So in terms of surveillance, again, trimodal therapy is an attempt at bladder preservation. This highlights the importance of surveillance and our role as urologists. There's no evidence-based schedule, but typical schedules include cystoscopy and cytology every 3 months for the first couple of years, then every 6 months for a couple of years, and then yearly for life, with imaging schedules similar to those for post-radical cystectomy. This, of course, can be tailored for patients who are ineligible for salvage cystectomy with perhaps slightly less rigorous surveillance. So what happens if we find recurrence? The non-muscle invasive bladder cancer recurrences are actually quite common. The rate is about 30%. And interestingly, standard management applies, though with some caveats. So you would treat it as if it was a patient who had not received trimodal therapy. However, these patients might have decreased tolerability of intravesical therapies, particularly BCG. And in general, you likely will have a lower threshold for performing a cystectomy if there are any high-risk features. We'll get to the rates of muscle-invasive bladder cancer when recurrence when discussing outcomes, but there's no evidence of increased complications in radical cystectomy with ileal conduit post-trimodal therapy. However, orthotopic neobladder, while not absolutely contraindicated, is associated with increased complications and is typically not recommended. We'll look a little bit at outcomes now. This is an image from an older study. It highlights nicely the unsurprising difference in outcomes between the different groups of patients receiving trimodal therapy. It's not noted on the image, but this is looking at overall survival. And the top line is patients who chose trimodal therapy. The middle group are the patients who are medically unfit for radical cystectomy, and the bottom group are those who had advanced disease or had unresectable disease. I should note that most of the studies on outcomes focus on patients who are eligible for radical cystectomy and have a choice between surgery and radiation. So this is a major systematic review which identified only 5 prospective phase 3 studies assessing trimodal therapy. There was otherwise a lot of heterogeneity in the studies with variations in inclusion period, patient selection, trimodal regimen, use of neoadjuvant or adjuvant chemotherapy, and duration of follow-up. And they demonstrated a broad range of disease-specific overall disease-specific and overall survival and salvage cystectomy rates. So en masse, this is not overly informative. Below is one of the largest published major academic center experiences from Massachusetts General. Many of these patients were on various RTOG and other trials, and they report quite promising outcomes, particularly with their more recent patients with disease-specific survival of 84%, overall survival of 75%, and salvage cystectomy of 16%. These are comparable to published experience of major academic centers with radical cystectomy in lower risk muscle-invasive bladder cancer. And this is an appropriate comparison due to the highly selected nature of the MGH cohort. The question remains, however, how reflective are these major academic centers with many patients in clinical trials and highly selected cohorts of the real world, reflective of the real world experience? Well, one of the largest real world experiences reported is actually Canadian. So it's a retrospective look at a large multi-center cohort over about a decade and a half with broad inclusion criteria. And for a nice comparison, we actually have a fairly analogous Canadian radical cystectomy experience. And if we consider the trimodal therapy patients who are fit for radical cystectomy, the 5-year overall survival is quite similar, and the salvage cystectomy rate is quite low. Now, it's actually quite difficult to compare series. There's staged discordance due to the availability of pathologic stage in radical cystectomy, but not in trimodal therapy. And this tends to favor cystectomy. There are also significant inclusion biases, particularly with trimodal therapy, where patients tend to be dichotomized between either highly selected patients or old and highly comorbid patients. So So how about a head-to-head comparison? The SPARE trial was a multi-center randomized control trial of trimodal therapy versus radical cystectomy in the UK. It closed in 2010 after 30 months due to low accrual. And they had significant challenges with clinician and patient preferences and non-compliance to randomization. Actually, almost a quarter of patients chose trimodal therapy after being randomized to radical cystectomy. And they also actually found that the optimal patient was not as common as expected. They had identified over 800 patients with T2/3 N0M0 disease, but on further look, less than 250 of these patients were truly optimal for trimodal therapy based on their inclusion criteria. And there's been no other head-to-head comparison since. The Princess Margaret group, who I've already alluded to, published their experience. And as a surrogate for direct comparison, they used propensity matching, and they matched 56 of their patients with trimodal therapy from their multidisciplinary bladder cancer clinic with 56 of their radical cystectomies. And they found comparable outcomes as well. But again, this is a retrospective study, and despite the propensity matching, still vulnerable to selection bias, and it also has quite low numbers. There are also a handful of contemporary large database studies attempting to compare the two modalities. The three which I've summarized here use the National Cancer Database, and then they use propensity score matching or inverse probability treatment weighting. And really, they arrived at similar results. They found a hazard ratio of approximately 1.4 in favor of survival following radical cystectomy. These studies, however, are limited by granularity, and there are therefore significant unknown confounders, particularly with respect to factors relating to indications for trimodal therapy, optimal patient selection, and treatment quality. As an example, the comorbidity status is not always clearly conveyed in the NDC-B. Criteria such as completeness of the transurethral resection cannot be collected, and the type, regimen, and timing of chemotherapy is not clearly identified.
Mark, can I ask a question about that slide?
Sure.
I guess you mentioned that you point out that it's hard to compare, obviously, and propensity weighted analyses always have issues with granularity, but the issues that you focused on were perhaps irregularities around the TMT treated patients. But wouldn't there also be similar challenges of quality with cystectomy patients?
So I guess the underlying point in these studies is that there's inherently a bias towards more comorbid older patients for radiation-based treatments. And this might not be fully captured in the NCDB. So there might be further unknown confounders, like the propensity matching might account for some of the confounders, but it's potentially not fully captured in the database.
Is the survival disease specific, or is it overall?
And it's also overall survival as well, yes. I don't think the NCDB doesn't provide disease-specific survival. So in terms of morbidity, we know that radical cystectomy is associated with significant perioperative morbidity and mortality, with a 64% 90-day complication rate and a 2.7% 90-day mortality rate or thereabouts. Trimodal therapy is, of course, also associated with acute toxicities, and these are mainly hematologic, genitourinary, and gastrointestinal, and are rated according to the RTOG grading, which is provided here, which I won't go through in detail. But in general, it's quite well tolerated with high completion rates. And what about late toxicities? We as urology residents dread hemorrhagic cystitis and countless hours of manual irrigation. But late toxicities do tend to be genitourinary, are mostly low grade, but grade 3 to 4 toxicities are approximately 3 to 8%. But in general, the rate of cystectomy for toxicity is low. And considering things from a patient perspective, in patients who have a choice between radical cystectomy and trimodal therapy, a major motivation is the presumed improvement in quality of life. However, there is poor quality of evidence on this matter, as highlighted by a 2015 review. It identified 6 small studies looking at quality of life, only 2 of which actually compared quality of life in trimodal therapy with radical cystectomy. And only 2 of these studies, and these were not the ones performing the direct comparison, were prospective. There was one additional cross-sectional study in 2016, which also attempted to make this comparison. But the findings in general were that both radical cystectomy and trimodal therapy both have good long-term quality of life. And the limited data are slightly in favor of trimodal therapy, but perhaps not as much as expected. And I think it's sometimes worth, I think it's something that's worth further investigation. One last outcome to consider is cost effectiveness. And here I've actually summarized and amalgamated results from 2 similar studies from the same group. They both use SEER and Medicare data, and once again, they use propensity score matching and inverse probability treatment weighting to compare the total treatment cost between the 2 modalities. They found trimodal therapy was significantly more expensive, about $110,000 US at the 1-year mark. And this was mainly driven by medication and radiology expenses. Interestingly, trimodal therapy was actually a lower cost when compared with radical cystectomy with neoadjuvant chemotherapy. So these cost differentials in the table are with both treatments without neoadjuvant chemotherapy. But once again, there are limitations to this study. First of all, this is limited by a 1-year time horizon, and both of these treatments may have associated long-term costs. And this is not a true cost-effective analysis. This is just absolute costs, and they're not looking at cost per quality of adjusted life year. And again, the data is not granular. They were looking at overall Medicare expenditures and not cancer-specific costs. And again, given that trimodal patients tend to be older and more comorbid, this is a potential source of a significant bias against trimodal therapy. Lastly, I'd like to briefly cover some novel developments in this space. As I've already highlighted, there are many clinical pathological predictive factors for trimodal therapy which potentially overlap with radical cystectomy. And the decision typically depends on either strong patient preference or significant patient comorbidity. But can we improve patient selection? If we return to the biology, the mechanism of radiation cell killing is via DNA double-strand breaks. Deficiencies in DNA double-strand break repair can therefore result in increased radiosensitivity. And tumors actually have frequent alterations in DNA repair pathways. This is a driver of genomic instability and tumor evolution. So it's reasonable to hypothesize that DNA repair pathways might yield predictive biomarkers for trimodal therapy. The most investigated molecule is MRE11, which indeed shows that expression and mutations are predictive of disease-specific survival following trimodal therapy, and importantly, is not predictive in radical cystectomy. Another relatively recent development is the use of transcriptional profiling to characterize muscle-invasive bladder cancer broadly into basal versus luminal subtypes. And these subtypes are both prognostic and predictive, with basal being associated with worse prognosis, but predictive for a better response to neoadjuvant chemotherapy. The MGH group performed transcriptome-wide genome expression profiling on tumors from 136 trimodal therapy patients, and they found that this was not predictive, the basal versus luminal subtypes were not predictive of trimodal therapy outcome. However, interestingly, in this same study, they looked at gene expression signatures suggesting tumor T cell infiltration, which was predictive of outcome in trimodal therapy, and again, not in radical cystectomy. So this is alluding to the relationship between radiation therapy and the immune system. So radiotherapy has an immunomodulatory effect. Radiation liberates tumor antigens and endogenous adjuvants, which promote androgen presentation cell maturation, which in turn causes T cell priming against the tumor. This is the so-called abscopal effect, and there's evidence of systemic response to radiation therapy with the regression of tumor cells outside of the radiation field. And this is consistent with the findings that high tumor T cell infiltration is predictive of trimodal therapy outcome. Now, checkpoint inhibitors activate the immune system through a non-redundant mechanism. They block signals which downregulate the immune response via CTLA-1 and PD-1. So the question is, are these two treatments synergistic? And can checkpoint inhibitors be used to potentiate the abscopal effect? Preliminary studies were predominantly in melanoma and lung cancer. And there's still no consensus regarding the dose of fractionation of radiation that is required to induce an abscopal effect, or the optimal relative timing of immunotherapy. However, we now actually have 3 trials exploring the potential treatment paradigm in muscle-invasive bladder cancer. The SWOG 1806 trial, the Keynote 992 trial, and the CTTG BL13 trial. And I'd like to highlight actually this last trial because it's a Canadian trial led by Dr. Kassouf in Montreal and locally by Dr. Khalaf. It actually just opened at BC Cancer Agency last week. This is a randomized phase 2 trial looking at trimodal therapy with and without adjuvant durvalumab in T2 to T4A disease in patients who are also fit for radical cystectomy and who may have received neoadjuvant chemotherapy with a primary endpoint of disease-free survival. So in summary, there are broadly 2 types of patients with respect to trimodal therapy. There are those who are fit for radical cystectomy, where we are attempting bladder preservation to improve quality of life. And then there are those who are unfit for radical cystectomy, where we are aiming to offer a lower morbidity, nonetheless high-quality treatment, and improve muscle-invasive bladder cancer outcomes. The oncologic outcomes seem to be comparable in appropriately selected patients, though there's still insufficient evidence regarding issues such as quality of life and cost effectiveness. Bladder cancer treatment is increasingly founded on multidisciplinary care, and this is doubly true for trimodal therapy. There is still a significant role for the urologist in this paradigm, with maximal TURBT, post-treatment biopsy surveillance, and salvage cystectomy being important elements. While the role for neoadjuvant chemotherapy is established in radical cystectomy, there is increasing traction for use with trimodal therapy as well, again highlighting the need for multidisciplinary care. And lastly, there's an exciting novel approach combining trimodal therapy with immunotherapy, which is currently under investigation and is very topical since it just became available here in British Columbia. So that's the end of my talk. I'd like to thank Dr. Black and Dr. Tildesley for providing guidance